I have the presentation already. I'm gonna share when I'm, in my turn.
Okay.
Okay, I think we can start. You agree, Guido? Okay. Let me introduce this webinar to everybody. Hello, everybody. It's an honor for me to host this webinar from the Italian chapter of the SSAT. And we are here today to speak about some of the most interesting topics in liver surgery with some of the outstanding speakers and discussants, with the hope to give you an important updates of different topics that are really those topics that we speaks on a regular basis on our international meetings. And I think we can start. And
okay, so we will start presenting the first. And the first speaker is Professor Timothy Pollack from the Ohio State University. Everyone knows him. And he will give a talk about lymph node and lymphadenectomy in liver surgery. And the discussant will be Professor Andrea Ruzzenente from University of Verona. Tim?
Thank you, Guido. Really delighted to be here today with the Italian chapter and all my great Italian colleague friends, and here representing the SSAT, which is a wonderful association that we hope that you all take a serious look at about participating in. So I'm going to focus my conversation today on intrahepatic cholangiocarcinoma rather than just kind of broadly construed lymph nodes lymphadenectomy for all liver disease. So I have no disclosures, except to note that we have had an international collaboration around intrahepatic cholangiocarcinoma for the better part of 15 or 20 years now. And I do want to acknowledge our collaborators in Italy, in both Verona and Milan, who have contributed significantly to this database and the data that I'll be sharing with you today. So our collaboration began to look at the issue of lymph node and lymphadenectomy for intrahepatic cholangiocarcinoma over a decade ago. And this is one of our first publications in JCO. And interestingly, at that time, our database was much smaller, only had about 450 patients in it. But even amongst high volume hepatobiliary centers, kind of the top centers around the world, lymphadenectomy for intrahepatic cholangiocarcinoma was only being performed about half the time. Flip of a coin. Half the patients got it, half the patients didn't get it. Among the patients who had a lymphadenectomy, interestingly, the median number of lymph nodes was 3, and the overall incidence of N1 disease was about 30%. But you could say, well, half the patients didn't even get lymphadenectomy. Perhaps all those patients who were NX ended up being N0. But even in that best case scenario, the overall incidence would still only be about around 20%. So these data have been confirmed over and over again, and that patients with intrahepatic cholangiocarcinoma, the incidence of nodal disease is in the range of about 20 to 30%. And like other GI cancers, colon cancer, pancreatic cancer, gallbladder cancer, nodal information is prognostically important. And we see here that patients with lymph node disease do significantly worse than those patients who are N0. And for that reason, for the first time in the 8th edition of the AJCC UICC manual, it was endorsed that all patients who undergo resection of intrahepatic cholangiocarcinoma should have a concomitant regional lymphadenectomy, evaluation of the nodal basin, and that this evaluation should include evaluation of at least six lymph nodes. So this is one of the first papers, and I wanted to put this picture here. We all know Fabio. We remember him well, and Andrea. And this was one of the first papers that looked at the AJCC staging system and indeed validated that patients who had N0 disease did significantly better than patients with N1 disease. And not surprisingly, patients with NX disease kind of had a mix, right? Because there was probably some patients with N0 disease and other patients with N1 disease in that group, and that led to an intermediate prognosis. I think what perhaps has been more controversial is, what is the ideal number of nodes that need to be evaluated? in the AJCC staging manual, it says 6 lymph nodes, but as I've shown you, it is difficult to get 6 lymph nodes. And some groups, like the group at WashU, have proposed that perhaps the ideal number of lymph nodes to get is 3 lymph nodes. And you can see here that when stratified by 3 lymph nodes, that patients who have N0 disease do significantly better, and there's less stage migration. And then similarly, this is a paper that we published in Annals of Surgical Oncology that showed that when patients have a adequate lymphadenectomy, that as designated by 3 or more lymph nodes, that you're able to adequately stratify patients with regards to prognosis. So if we look nationally, you can see that overall, the majority of patients who undergo a lymphadenectomy, the median number of lymph nodes that is indeed evaluated is only about 3%. And there's only about 15 to 20% of patients will reach this 6 lymph node threshold that has been set out by the AJCC. And if you look at national data, in fact, only about 40% of patients even have 1 lymph node evaluated. So we have a ways to go with regards to being compliant with the AJCC staging manual and assessing nodal basin. And again, I think this is important because if we look at AJCC staging with the T categories, these are based on tumor size, tumor number, and the presence of vascular invasion. But if we don't get the nodal information, we might as well not stage the patient at all, because really the T categories are only prognostically significant in those patients who have N0 disease. You can see here that patients who have vascular invasion, there's really no prognostic discrimination in the N1 group. And similarly, patients who have single or multifocal disease, there's no prognostic discrimination amongst patients who have N1 disease. And that's really because it's a competing risk model. And once you have nodal metastasis, what's driving your long-term survival is the fact that you have regional metastases, not what the T category is: single, multiple, vascular invasion, no vascular invasion. So again, I think these data would be very strongly suggest that you need to have the nodal information to stage the patients accurately. So there's been a lot of conversation around, can we identify which patients need a lymphadenectomy and which patients don't need a lymphadenectomy? And in this paper, we looked at patients who were deemed to be low risk, so maybe smaller tumors, single tumors, no vascular invasion, versus high-risk patients. And you can see here that in high-risk patients, indeed, there was a slightly more kind of therapeutic value to the lymphadenectomy, but it really wasn't dramatically different than those patients who had a kind of low-risk disease. The other thing is, whether we should decide whether we should do lymphadenectomy based on morphologic subtype. So in this study, we looked at patients who had mass-forming lesions versus those patients who had peripheral infiltrating lesions. And interestingly, you can see that empirically, surgeons are dictating whether they do lymphadenectomy or not based on preoperative imaging. So you can see here, patients who presented with mass-forming lesions, if the surgeon thought that the preoperative scan looked negative, not suspicious for lymph node metastases, then a lymphadenectomy was only performed about 37% of the time. But if on preoperative scan, they were deemed to have suspicious lymph nodes or positive lymph nodes, then the surgeon went ahead and did a lymphadenectomy 75% of the time. So I think these data are showing that we are trying to assess preoperatively based on the scan who we should do a lymphadenectomy on. And on the right side of the screen, it's showing pathologically what we find. So interestingly, if the scan looks negative and you still do a lymphadenectomy, we're finding nodal disease in up to 25% of patients. So still 1 in 4 patients have a positive lymph node. And if the scan looks suspicious or positive preoperatively and you do a lymphadenectomy, then we're finding nodal metastases on final pathology about 50 to 60% of the time. So this is another study where we again looked at this idea of whether we could use preoperative imaging to better identify who needed a lymphadenectomy. And what we did actually is we combined imaging, so whether the lesion or the lymph nodes were suspicious or, frankly, metastatic, with other tumor-specific factors like the CA19-9 level or ALBI grade. And what you can see here is that we developed kind of a calculator, if you will, but unfortunately, this does not perform overly well. The AUC is still in the range of only about 0.7. So 30% of the variability is being missed by using a calculator that takes into account not only preoperative imaging, but CA19-9 level, ABLI grade. And so I would advocate that you really can't predict, who has lymph node disease preoperatively, and everyone should have a lymphadenectomy who has intrahepatic cholangiocarcinoma. And I think the other thing that's interesting is this is a different study that we published showing that even in patients with early stage disease, T1B disease, the incidence of lymph node disease is about 15 to 20%. So even in early T category disease, the underlying incidence of nodal metastasis will still be relatively high. And you can see once you get to T3 disease, the incidence of nodal metastasis can be in the range of about 50 to 60%. So again, I think that everyone with intrahepatic cholangiocarcinoma should have a lymphadenectomy. I think the lymphadenectomy also needs to be informed by where the tumor is located. There's a laterality to this and the nodal drainage from the liver. And on tumors from the right side, we know that the lymphatic drainage goes to groups 1 and 2, and that's typically what I try to harvest, the hepatoduodenal ligament, station 12, but then also station 13 behind the pancreas, and then along the hepatic artery and celiac axis 8 and 9. But in those tumors that are on the left side, I also think it's important to harvest stations 1 and 3, because the drainage from the left side can also go to those nodal basins. And this is another study that we looked at, whether the lesion was on the right side or the left side of the liver. And what we can see here is that there was no statistical difference between where nodal disease was discovered, either within station 12 or beyond station 12, relative to the sidedness of the tumor. But interestingly, tumors that were on the left side, the median number of lymph nodes was slightly higher at 5, whereas on the right side, again, it was only 3. Again, missing this elusive 6 nodal threshold that is being asked for by the AJCC staging system. And what we can see here is that the overall incidence of N1 disease was in the range of about 45%. And was slightly higher on the left-sided tumors. And I would argue that's probably because the nodal harvest was higher on the left side. So there's probably less kind of missed nodal metastasis because the lymph node yield was higher on the left side than it was on the right. But overall, the number of metastatic nodes that was discovered was the same on the right side and the left side. And here you can see the survival curves, which again demonstrate that those patients with N0 disease do significantly better than N1 disease, and then NX patients have an intermediate prognosis. So I think the number of lymph nodes is important prognostically, but also the location. And this is a paper that demonstrated, perhaps not surprisingly, that patients who had nodal metastasis beyond station 12 had a significantly worse outcome than patients who had nodal disease within station 12, suggesting that like kind of this maybe second echelon nodal metastases leads to a worse overall prognosis. So we've talked a lot about like the prognostic significance of lymph nodes and lymphadenectomy for intrahepatic cholangiocarcinoma. But I think more controversial is this idea is, does it provide like a therapeutic benefit? And I think perhaps it does. It's hard to prove. I think one issue for biliary tract tumors is that we know that for recurrence, about 20 to 30% of the time, recurrence will occur in the regional nodal basins. And if you have bulky recurrent nodes in the hilum, this can cause biliary obstruction and worse quality of life. So I tend to think that perhaps there is some local control that can be achieved by doing a lymphadenectomy at the time of surgery. And then perhaps even more controversial is, whether there is a survival benefit from doing lymphadenectomy. And the Japanese have proposed this concept of therapeutic index relative to lymph node evaluation and harvest, which has been popularized for gastric cancer. Obviously, there's been tons of conversation about the therapeutic benefit of lymphadenectomy for gastric cancer. But what we found for intrahepatic cholangiocarcinoma is that perhaps there is a therapeutic benefit for those patients who paradoxically have earlier stage disease. So for those patients who have vascular invasion or high CA19-9 level or lymph node metastases in a second echelon, their biology is so kind of bad that probably lymphadenectomy is not going to provide any type of therapeutic benefit. But perhaps for those patients who have earlier stage disease and have a micrometastasis in their lymph node, that better surgery or more extensive surgery can improve their outcome. And that's what this study suggested. But I think the other thing that's important is that, informing clinical trials and adjuvant therapy, these are some retrospective data showing that patients who have nodal disease seem to preferentially benefit from adjuvant therapy. And we're all familiar with several prospective trials that have suggested a benefit for adjuvant therapy. And I will say that one of the differences between the BILCAP and the PRODIGE trial was that it seemed that patients in the BILCAP trial was a little bit enhanced for patients who had more nodal disease and worse biology, again, suggesting that perhaps patients who have nodal disease would benefit from adjuvant therapy. And so, at least in my practice, I refer all patients for consultation to medical oncology. And if they have nodal disease, almost 100% they will be offered adjuvant therapy. So in conclusion, hopefully I've demonstrated to you that lymphadenectomy has an important role in the treatment of patients with intrahepatic cholangiocarcinoma, that the overall incidence of lymph node disease in the setting of intrahepatic cholangiocarcinoma, ranges anywhere from 20 to 50%. And even patients with T1 disease can harbor lymph node metastases, 15 to 20% of the time. It is very difficult to identify preoperatively using tumor markers or even scans who needs a lymphadenectomy or who doesn't. So I recommend that everyone get it because it will inform prognosis. It may inform adjuvant treatment, and more kind of controversial, if you will, it may provide a benefit either due to local control or even with regards to the therapeutic index and a survival benefit in patients with earlier stage disease. So with that, I'll conclude. Again, I'd like to thank Guido and the entire Italian surgical chapter and the SSAT for allowing me to participate in this webinar today. Thank you very much.
Thank you very much, Tim. Now there is the comment of Professor Uzzonente. Andrea, will you please?
Yes, thank you. Thank you, Tim, and thank you for the SSAT for inviting me to comment the presentation of Timothy Polik, that is very expert about intrahepatic cholangio, the role of lymph nodes, and a very good friend of mine, and we have a long-lasting collaboration with him. And I want to stress that Professor Polik underlined the importance of lymph node dissection also in small tumors. And a few years ago, we published a paper for small intrahepatic cholangio. And even in smaller cholangio, smaller than 3 centimeters, the rate of lymph node metastasis was about 30%. And I think it's important to stress that in these patients is far more important that in advanced case that lymph node dissection can have a prognostic role. So based to this comment, I want to ask you, Timothy, what is in your opinion, if there is any molecular determinants of lymph node metastasis? We know that in intrahepatic cholangio, we are growing our experience in molecular profiling and identifying some molecular subtypes that are more favorable and less favorable, like ADH1 mutation or FGF receptor 2 mutation. So, in your opinion, there is some differences in the rate of lymph node metastasis accordingly to different molecular subtypes. Which is your opinion about this?
Yeah, I am not familiar with any molecular marker now that with high fidelity can predict which patients have nodal disease or don't have nodal disease. I mean, there's obvious, molecular perturbations, whether it be IDH1 or BRAF or, KRAS, things like that, that have been associated with prognosis for patients with intrahepatic cholangiocarcinoma. But I'm not familiar with any molecular marker that's kind of prime time to inform, who's at highest risk for nodal disease and would inform who to do lymphadenectomy on and who not to do it on.
Yeah. Thank you. And which is your current clinical practice about diagnosis of lymph node metastasis? Do you advise to do MRI or PET scan if you suspect for identifying metastatic lymph node?
Yeah, it's a good question. So, I didn't talk about this a little bit, but I tend to use a fair amount of PET if I'm suspicious, because I think patients who have nodal disease, their prognosis is poor. In other papers, that we've published and other people have published, that very early recurrence is not uncommon, especially in the setting of nodal disease, especially if the nodal disease is outside of station 12. So for those patients, I would offer them preoperative chemotherapy with a GAP protocol or otherwise, and then only operate on them after I've assessed their biology. So I tend to use PET. I tend to use MRI as first line. I prefer MRI over CT. That's just me. And then I use PET. And then someone asked about EUS. We don't use a ton of EUS. I think that if, because if the PET's positive, the PET's positive for the nodal disease, so, in a situation, I guess, where the lymph nodes look like very suspicious, but the PET was negative, would we do EUS? Yeah, maybe. But that's pretty uncommon.
Okay, so the last question, Timothy. We are pushing a lot on the minimally invasive surgery because we appreciate the results of minimally invasive liver surgery, both with the robots and laparoscopy. But there were some concerns about the oncological outcome of minimally invasive approach for gallbladder cancers and intrahepatic cholangio. A paper coming from the US demonstrated a lower rate of lymph node dissection in the minimally invasive approaches, and they suggest they arise some concerns about this approach. So which is your opinion about the surgical approach? So do you advise to wait more results to advise for the minimally invasive, or do you believe that is oncologically adequate, also robotic or laparoscopic approach?
I think it's oncologically adequate. So, just when I was just in Rome, right, for ILS, about a month ago, we had a long conversation about this at that meeting. And I'm embarrassed, I can't remember, but one of the surgeons, I think she was from Milan, I can't remember, but presented some compelling data to show, at least in that center, the nodal harvest was the same and perhaps even higher. Because I think on the robot, the visualization is quite good. And I think even retroportal dissection with the robot, the visualization. So if anything, I think there are other data to suggest that the robot will create greater visualization Yeah, someone's right. Yeah, it's from Luca's group. That's right. It was from Luca's group. So, and Luca's group presented data that the nodal harvest was the same or even higher. So I think in expert hands like Luca and other people at his group, I think the nodal harvest is the same, or perhaps even better. So I have no qualms about approaching this from a robotic or minimally invasive approach. Obviously, in the right hands, people who have expertise like Dr. Aldrighetti and others.
Okay, thank you so much, Timothy, and thank you for SSAT for the honor for a comment in your presentation.
Thank you, Andrea. Thank you.
So that Matteo, could you introduce the?
Yes. The next speaker will be Nadia Russolillo, who is a surgeon in the Department of Surgery at Umberto I Mauriziano Hospital in Turin, which is a very well-known institution with a long-standing history in HPV surgery. And the discussant will be then Eduardo Vega, who is an HPV surgeon and assistant professor of surgery from Boston. Thank you, Nadia, please.
Can you hear? Okay, now you hear me? Okay.
Yes.
Good morning and thank you. I'm very honored to be here. Thanks, Professor Torsilli and Donadon, to share. I'm very happy to share with you on this topic. Okay, if we picturing the quality in surgery on a scale, at the first step we found the standard quality that can be that's defined as the minimum level of acceptable performance. This value set the expectation of patient and is the heart of the relationship between patient and doctors. On the other hand, we have the best results achievable, the benchmark, that set the ambition of the surgeon and can be used to improve the performance of surgeons and centers. Between these two extremes, we have all the type of results, including the high quality results that are generally associated with high volume centers. And in the next minutes, I try to give you some data on the most common performance indicators, in particular on CCI that quantify the burden of postoperative morbidity, the textbook outcome that define the ideal outcome of surgery, of course, also the benchmark, the best results achievable. The most common classification to describe and compare postoperative outcome of our patients is the Clavian-Dindo classification that we know ranks complication according to the degree of invasiveness required to control each complication of our patients. The main limits of this classification is that it's based only on the single most serious complication occurred, whilst the CCI try to overcome this limit and summarize postoperative morbidity based on Clavian classification with a numerical scale ranging from 0, no complication, to 100 that represent the death of the patient. And many studies try to compare the performance of Clavian-Dindo classification and CCI, and we'll present you this multi-centric Italian study that compare more than 2,600 patients with hepatocellular carcinoma that underwent a liver resection, and they found that CCI was slightly superior to Clavian classification in predicting both the length of hospital stay and the prolonged length of hospital stay. And similar results were reported in other surgical fields, for example, pancreatic surgery, but also gastric surgery and after major abdominal surgery. So probably when we describe our results of our patients, it's better to use the CCI. According to CCI, a patient that underwent a liver resection without a postoperative complication and the CCI of 0, any surgeon will be happy for these results. But we know that there are other factors that can affect the satisfaction of surgery. For example, in patients with oncological disease, the ability to perform a radical resection is a key point. The problem is that in the first part, we use a monoparametric evaluation, but probably we need for a multi-parametric evaluation. And the text outcome is the tool, a composite measure, a multidimensional measure that, including a different factor, try to describe an ideal outcome after surgery. A recent review reported that there are very many different definitions for benchmark for textbook outcome in liver surgery. Some factors are present in almost all the definitions. For example, no prolonged hospital stay, radical resection, no readmission, no death, no complication. And according to this paper, the crude value of textbook outcome achievement in liver surgery is almost 14%. But we know that there are many factors that can affect these results. For example, the diagnosis. The best results are achieved in the patient with colorectal liver mets, and the worst results in patients with biliary cancer. And there are also other important factors, some related to the center, for example, the liver volume, the volume centers, the liver cancer dedicated centers. And other factors are related to the patient, for example, the presence and the number of comorbidity, the social vulnerability index, the Charlson index, but also the liver function according to the MELD score or the presence or absence of metabolic syndrome. And finally, obviously, the achievement of textbook outcome is related to liver surgery. The extent of operation, major versus minor liver resection, the type of associated liver resection, for example, vascular biliary surgery, and finally, the type of approach. So it's clear that before you use textbook outcome to compare results, it's important to perform a risk adjustment. Finally, regarding benchmark, Rosler et al. For the first time tried to calculate benchmark, the best achievable outcome, in patients after open major liver resection. And they analyzed only the best patient defined as the living donor, treated in the best centers defined at centers that performed at least 15 cases of adult living donor, and analyze the two procedures, right hepatectomy and left hepatectomy separately. In this very selected population, they defined benchmark as the 75th percentile of all center-specific and median value. This paper opened the road for the calculation of benchmark in different surgical fields, including in laparoscopic liver surgery. And other studies try to use the cutoff of 75 percentile. For example, this study that comes from the French registry, the author analyzed the all patients of the French survey, not the best patient, but all patients, treated in the best center that was defined according to the number of laparoscopic liver resection per year, with a cutoff of 25 liver resection in the case of benchmark for left lateral sectionectomy, and 13.5 laparoscopic liver resection in cases of benchmark for right hepatectomy. And the last paper in this, with this focus is a paper, a multi-center study that defined the so-called global benchmark. Also in this case, they use the 75 percentile, but analyze the best patient, defined as patient with a very good performance status, no cirrhosis, no gallbladder cancer, that received no high-risk surgery, for example, ALPS or associated resections, treated in the best center that were defined as center that performed a global number of 18 consecutive laparoscopic liver resection, with a number of at least 20 liver resection per year, and that published at least one PubMed paper on laparoscopic liver resection. And finally, the IGOMILS registry, the Italian registry of laparoscopic liver resection, tried to calculate benchmark using a different method, the ABC method that is already published in other surgical fields. According to this definition, we analyze all patients of IGOMITS registry, treated in all centers of the registry, performing only correction for the number of patients per centers. And we analyze 3 types of group of laparoscopic liver resection according to the IMM classification. In this very unselected population, we the value of benchmark is defined as the 10th percentile of all center-specific median value. In this table, try to compare the results with according to the different definitions. It's very interesting to note, for example, after right hepatectomy, that the benchmark value, the best achieved outcome, for example, for morbidity rate after right hepatectomy is 17% in case of our IGOMITS registry, but almost 15% in the French survey and global database. And similarly, the conversion rate range from the 8% of the IGOMITS registry to 30% of the French survey. So the problem is in which point of this scale we can place this value. So in other words, a 50% of postoperative morbidity, a 30% of conversion rate can be considered the best results, the benchmark results, or a high quality or standard quality. And this is a very important question because the main goal of benchmark is to perform gap analysis. So each surgeon, each center can compare their results with benchmark in order to identify the room for improvement, the key factor to obtain this improvement. It's clear that both the method, the ABC method and 75% have some limitations. Both require risk adjustment analysis, of course. The IBC method comes from Italy, only one country. We don't know if it's correct to use the same benchmark value for all the procedures included in the same group of IMM classification. And regarding the 75 percentile, we know that the rate of best cases in each center is low. And we don't know if the benchmark value valid for no best cases is valid for no best cases. In conclusion, we need to standardize the benchmark and the textbook outcome definition, and because there is always the best way of doing everything. Thank you for your attention.
Thank you very much, Nadia, for this very nice and clear presentation. I think, Eduardo, it's your time, please.
Yeah, thank you, first of all, for the invitation to the SSAT and the Italian chapter. I really appreciate that. And thank you, Nadia, for providing me your presentation in anticipation to this discussion. I do have 3 questions. First of all, I would ask you, how can healthcare institutions balance the pursuit of high-quality surgery with the need of efficient cost effectivity? And that means, do you have any data that it simultaneously enhancing costs of the quality of the surgery, reduce the cost of the surgery? And then talking about more about what you mentioned about happy surgeon, unhappy patient, that I see is a key point here. For the patient viewpoint, how do these performance indicators influence their confidence and undergoing surgical procedure? What should we share with the patient? What is the limit? Should we do full transparency or should we share? And how can we gonna define that? And the third question, more in relation to that, to be an unhappy patient being with a happy surgeon, is what can we incorporate into those quality measure to the performance indicator that might give feedback about how is the patient experience during the surgery?
Thanks
so much.
Thanks for your question. I think that healthcare institutions have to analyze cost effectiveness studies that included both consider not only surgical costs, but also the social cost of disease. For example, in the case of a minimally surgery, it's clear that minimally surgery is more expensive than open surgery. But if we consider not only the reduction of the postoperative morbidity, but also the time needed to return to normal activity, it's more hard to not consider minimally surgery as cost effectiveness. So I think that all strategy focusing on quality are probably cost effectiveness. Regarding the second question, I think that both CCI and benchmark are very useful for surgeons, but are too complex to understand for patients. In contrast, the textbook outcome, I think it's more easy to understand, and I think that can be used to share with patients transparent information about the probability to obtain an ideal results, and this way setting the expectation of the patient. And finally, for the third question, in this moment, all the indicators that we use consider the surgical point of view, but not the patient point of view. And this is a big problem. And I think, for example, that quality of life is very important when we analyze the quality of our surgery, and especially in some settings. I think, for example, patients with the pancreatic cancer or Klatskin tumor that have no long overall median survival and underwent an high-risk surgery. In this case, it's very important to include the quality of life in our parametric indicator.
Thanks, Nadia. If you have to choose one, which one would you use, and which one is the one you're going to keep using? Because, yeah, I think we have published about the benchmark, and but the problem is that the benchmark, the objective of the benchmark is not just to be published, is to be used to improve.
Yeah. If the aim is to talk with the patient, I use textbook outcome. I think it's more easy. If the aim is to improve my activity, I prefer the benchmark in order to understand the room for improvement for me and my center. But the problem in both cases is the definition. We have to work to standardize the definitions.
Okay, thanks so much.
Okay, thank you very much. I don't see any other questions, so I think we can move on. Guido?
Okay. We will move to the lecture of Professor Giuliante from Rome, liver first approach for synchronous colorectal liver mets, and the discussant should have been Dr. Chin, but as Professor Rotte told, is probably busy, and we will try to animate ourselves the discussion. Felice?
Thank you very much, Guido. Thank you very much for the invitation to participate to this webinar. The aim of my presentation is to discuss with you the role of liver first approach for the treatment of synchronous colorectal liver metastasis, for which we have three main options, basically. That is the simultaneous resection of the metastasis and of the primary tumor, and the stage approach, moving first the primary tumor resection, or the liver first resection, the so-called reverse approach. Wait a minute, okay. The choice depends on several factors, that is, the features of the primary tumor, if it's symptomatic or not, if it's a colon or rectum, the features of metastasis, resectable, easy or with a complex resection, or if they are unresectable, and of course the general condition of the patient. So the strategy remains controversial. We do not have randomized controlled trials, at least robust ones. We have at the moment this very recent multi-societal European consensus based on the previous multidisciplinary international consensus. And one point on which there is a general agreement that for these patients, for the majority of these patients, systemic chemotherapy should be the preferred first treatment. And this is coherent with our activity. You see our experience, and in the last years, 80% of, more than 80% of our resections for synchronous metastases are made after preoperative chemotherapy. So whenever is possible, the suggestion is to combine the resection when we do not have an increased operative risk, because of course there is one operation, no delay in the treatment of metastatic disease, of course. But this is a work coming from the group of Professor Polik, in which is shown that less than 7% of the cases are dealt with a combined colon, rectal, and liver resection. So it's a minority. It is true that it has been an increase in the use of this approach, but actually the increase regards only the so-called low-risk patients and procedures. And on the opposite side, we have the reduction of the use of this approach for medium and high-risk patients. Same results come from this other paper coming from the experience of 5 hepatobiliary centers, in which you can see that there is a trend toward an increase of the use of simultaneous resection, colon and liver. But actually, there is a simultaneous only in case of minor liver resection. On the opposite side, there is a decrease for the use of major liver resection in a simultaneous setting resection. So over the recent years, moving to liver-first approach, this has been used more and more frequently. This is a global survey in which they analyzed the answers of more than almost 300 surgeons, and almost 60% of the respondents said that liver-first was the preferred approach. More frequently in North American and European surgeons, less frequently in the Asian ones. And this is very interesting data. Of course, we have a good impact of the use of minimally invasive technique, mainly in combined approach. We are participating to this multi-center trial study, which is recruiting on this topic. We will see the results in the next future. And when the problem is that when we cannot do a simultaneous resection, we have to choose a stage approach, colon or liver first. So we have to, I think, try to answer to this question: to which side is mainly related the prognosis? In other words, where is located the main tumor load, the colon, the rectum, or the liver? And the idea of the liver-first approach, which was first described by Gilles Menta several years ago, is that when hepatic disease is predominant and major liver resection is necessary, liver-first approach could be preferred in a patient with primary tumor with asymptomatic or symptoms easily to manage. Actually, if we move back to the consensus, the European consensus, the recent ones, liver-first approach is suggested for liver tumor burden when liver tumor burden is large, especially for rectal cancer, to be considered in borderline or technically complex resectable synchronous liver metastasis, and when we have response to chemotherapy, speaking of rectal tumors. Actually, in the literature, you will see that 2/3 of the cases in whom a liver-first approach has been used, there was a case of rectal cancer. So this is the preferred setting. This is an example in which we use this kind of approach, several liver metastases. You see the patient, of course, was sent to chemotherapy first. This is the response, the partial response after chemotherapy. So the high tumor burden was in the liver, so we choose to perform a liver first resection with multiple parenchymal sparing liver resection, then chemotherapy after the resection, and 5 months after liver resection, laparoscopic rectal anterior resection. And then recurrence, 17 months, resected, a recurrence again, the third resection, and the patient is now alive without recurrence at the moment. This is another example, huge metastasis, liver metastasis. You see the extremely high tumor liver burden. So chemotherapy first, of course. This is the response. We decided once again to perform a liver first resection, but in this case, we preferred a two-stage approach. And actually, this is one of the few cases in which we use an ALPS approach, with the first resection of the caudate of the segment 2 resection, and then after 9 days, you see the increase of the left liver, and we completed the second stage. And 2 months after liver resection, sigmoidectomy was performed, and this is the results after 22 months. So the arguments favoring liver first approach is the immediate control of liver disease, the selection of patients with possible favorable disease, and it avoids the risk of progression of liver disease while treating the primary tumor. And for rectal cancer, liver resection can be performed between radiotherapy and rectal resection. Actually, we can perform the liver first before a radiotherapy in a short course fashion, and then a rectal surgery, or in between, waiting for the accomplishment of the long course radiotherapy before rectal surgery. What about the results? Well, this is one of recent paper in which the three approaches, bowel first, liver first, synchronous surgery, have basically the same survival probability, but the numbers are very, limited. This is the most recent one in which, from Sweden, in which you see the similar results of the three groups, the same after matching of the population, kind of the same results from French experience. And we had the possibility to evaluate the results of the LiverMets survey registry, more than 500 patients treated with liver first approach, more frequently rectal tumor, more frequently high liver tumor burden in the group with liver first approach. And we tried to understand if different prognosis exists in relation to the severity of the metastatic disease. So no difference in case of single metastasis, no difference in case of multiple unilobar, but there is a difference in case of multiple bilobar colorectal liver metastasis in good population and compared to primary first and simultaneous, and also in the matched population. This is a quite important data. This is a paper focused on the rectal cancer, on the use of liver first approach in rectal cancer, coming from the group of Professor Botey. And one data is that the classic, that is the primary first approach, is going down, less frequently used over time. And the patients in whom they were treated with a reverse approach had a more advanced and aggressive disease. So median number, higher median number, bigger size of metastasis, and so on. And you see that the overall survival is the same. But in this experience, this is in spite of more advanced and aggressive disease. So this is a result. A result favoring the reverse approach. In our experience, 73% of our liver resection are performed for synchronous metastasis, but only 1/3, more or less, we can manage from the diagnosis of the disease. And at the moment, in this group of population, 25% of cases are treated with the liver first approach. The problem is, of course, the dropout in median 20% of patients. That is the not completion of the strategy, and this is mainly for metastatic progression. Of course, this is a big problem, because there is a big differences of overall survival in the two groups, 45 months, 13 months. You see the plot here. And is related mainly, according to this meta-analysis, to the high number of lesions and large metastases. And in the MD Anderson experience, you see how changed the cumulative survival for those patients in which was completed the reverse approach, and in those patients in which the reverse approach was not completed. And in this case, a multivariate analysis, the authors found that the commutation of RAS at TP53 is associated with a lower rate of completion of the reverse approach. So the conclusion is that the choice between the three approaches, and in particular for the liver first approach, is should be performing a multidisciplinary team for, personalizing the treatment. So the management of these patients is complex, remains controversial. These three approaches are not mutually exclusive, but should be proposed to different types of patients with different charges of burden of disease, and with different profiles of surgical risks of the patients. Liver first approach usually is preferred in patients with high liver tumor burden, mainly for rectal cancer. Mean invasive approach can have a good impact, for improving the results of all strategies. I don't know if can be and how can be the exact role in liver first approach. We will see the results of the trial recruiting. Multidisciplinary evaluation is crucial. One point is the need of better definition of factors increasing the risk of non-completion of liver first, because this is the main problem of this approach. Thank you for your attention.
Thank you very much, Felice, for this nice talk and really comprehending all the aspects of this debate, still debated, and I think will remain still debated issue, because it regards several aspects, such as the evaluation of the risk of each kind of surgery and the combination of the risk. And then there is the good clinical practice, the habit of the surgeon, the kind of approach, several, and also, and at the end, when there is uncertainty, we always address to the multidisciplinary team the final sentence, which is anyway a good, and also the different expertise of the team. It depends also on the fact that nowadays with the super specialization, it is not rare to have the colorectal surgeon team and the hepatic surgeon team. And in this sense, as we, and I guess also in your institution, you have, no? And then there is a combination of two different, and also in this sense, I think it is very important the working together of the two teams and the habit of the kind of surgery that they are doing. In example, do you have an idea in how many of the paper released this kind of habit of separating the two teams in the synchronous approach is?
Well, yes. Thank you for this question. This is is important topic, because the expertise of the colorectal surgeons and the expertise of liver surgeons may have an extra positive impact of the procedures. We have data coming once again from the Italian experience in the consensus conference about the synchronous metastasis, and in this consensus, 50% of the participants of the many centers participants have different teams, but this means that in the 50% is the opposite. So it's in my opinion, it's in our experience, we use different teams. We collaborate with the colorectal surgeons when they perform a rectal resection, and we perform a simultaneous liver resection only if minor resection is affordable. Of course, this is our policy. And I don't know what is your attitude, if you prefer always to separate or try to, whenever it's possible, to combine the procedure, which would be, I mean, the best, because of course it's one operation for the patient would be the best option.
I agree.
This is the only.
Yes.
This is the only data that I have at disposal concerning the double, team or a single team in the clinical experience.
You know, the one paradoxically, we have a similar approach. We have a very strong colorectal team that is also very active in research on their own aspect and in the minimal access approach and whatever. Paradoxically, there could be when the two teams are
high level
in terms of activity and level of the level of activity. Of course, there should be a very symmetrical way of working and exchange, because everyone would like to have a prominent role in the management of the patient, and also the patient, according to if the patient is referred to the other or to the other team. So in this sense, this could play an important role in the appropriate management. But at the end, I think the high specialization of the teams is profitable
yes, but this
point of view.
This is very important evaluation, the reference of the patient. But I think that at least in our discussion, the important point is to try to decide together where is the main tumor burden, in the liver or in the rectum or whatever. So moving from this point, we try to decide the policy, the strategy.
Okay, I fully agree. And is there any other question?
I had seen Eduardo Vega, maybe.
Yeah, I wanted to ask you, Professor, in your experience, how many of those patients that we call liver first approach do have to have some diversion, some ileostomy, colostomy, and if none of them, do you have any cases where the liver first approach because of obstruction failed because of obstruction? And if you know anything about that, may help to predict those patients who are not going to be able to complete the liver first approach.
Well, no, it's not. No, I'd say, first of all, we choose to perform a liver first approach when we have a response not only to the liver metastasis but also to the primary tumor. So, I have to say that we do not have. I mean, the main reason for not completion of the approach is related to the progressive of the liver metastasis, of the appearance of metastasis in extrahepatic sites, locations. And if you see also, if I remember well, the experience of Professor Botei, they had a small rate of diversion, or need of diversion in these patients. So I don't think this is a strong point to decide, toward a liver first approach or not. The prerequisite is the response to chemo radiotherapy, if there is also radiotherapy for rectal cancer. In fact, in the consensus, in the last consensus, there is a statement saying that it is to avoid it. I mean, we should avoid to think about the liver first approach if there is no response in the primary tumor. This is my opinion. I don't know if I answer our question.
Yeah.
Okay, thank you very much. I think that we can move on. Matteo, can you?
Yes. The next speaker will be Svanto Sukandi, who is a rising star in robotics. And he will talk to us about how to transect the liver in robotics surgery. And the comment will be done by Dr. Riccardo Memeo from Bari, who is similarly a young rising star in robotics in Italy. Thank you, Svanto. Please.
Everyone, thank you, Matteo. Thank you, Guido, for the invitation to participate in this conference. I'm going to share my slides here. Are we able to see the full slides?
Yes.
Yeah. All right. So my topic today is transection technique in robotic liver surgery. And this is an evolution that I think occurred mostly in the last 5-10 years in surgery. So as we can see here on the screen, we actually have published quite a bit of papers centering around the technique of doing a robotic liver section from the right lobe, full anatomical resection to the left. And also we have described our technique for a carotid lobe resection, as well as for the Klatskin tumor of various types, from type 2, 3A, 3B. And this is available on the online, so we can look at this later. So I just want to summarize the standardized technique of robotic liver resection is actually similar to open liver resection. This is not a new operation. It is just operation that is done in a different approach, but the essence of the operation is the same. So technically inflow control with ligation, hepatic artery pole vein, and we go on to parenchymal transection, then hepatic duct division, and then last is hepatic vein division. Now, what is different in robotic liver resection is, I think, the parenchymal transection, which has to be done in using an instrument that is available currently with robotic system. As we know, CUSA is not available for robotic system at this point. Therefore, we are using vessel sealer, harmonic scalpel, synchroseal, and crash clamp technique, either using a bipolar or two Marylands, both the right and left hand, to do the transection. And you will see a couple of the videos describing the different technique, because I think the video will be the best to explain these different techniques. So this is first technique is transection utilizing a two bipolar on the right and left hand, and both of them can be connected to the bovi. So it means the right hand and left hand can simultaneously deliver energy of hemostasis. And the instrument come at a different shape and size, but the most commonly used is a long bipolar grasper and Maryland bipolar forceps, and they can be cleaned intra-abdominally using a piece of gauze that is placed into the abdomen, so that you don't have to exchange the instrument so many times, which is can be time consuming. So the next energy device that currently available on the market is a vessel sealer. This is an articulating instrument that comes with a robotic system. It is good for curved transection plane. So if we do a non-anatomical resection up in a segment 7 or 8, and this is probably the best instrument, it can handle 7mm carable, and it can also sustain a threshold of 3 times of systolic blood pressure. So this is actually quite effective for hemostasis with 1 to 2 centimeter lateral thermal spread. This is always a concern as well, that we can cause injury, thermal injury to the bile duct, and later strictures. The other version of this energy is a harmonic scalpel. I think most surgeons are quite familiar with the harmonic scalpel, because we have been using this for laparoscopic for about 20 years. The issue is this is their straight instrument without articulation, and it can also handle 5 to 7mm caliber vessel. The active blade can be used as CUSA like a method where you actually activate the metal blade while touching the tissue with the metal blade side to side. And the intention is to remove the parenchyma and only leave the biliovascular vessels to be handled with either energy or clip. A bit downside of the harmonic scalpel, in addition to the straight instrument, is actually have a bit of a thermal spread. It's a 2.4 millimeter thermal spread, so we have to be cautious applying this energy at the halar plate area. These are two different videos at the two different phases of the operation that I want to share with all of us. The left side, the video is intrahepatic cholangiocarcinoma in the segment 4A. And the right side video is a large hepatic hemangioma in the segment 2, 3, and pushing on segment 4. And you can see here the reconstruction on the left side showing the proximity of the tumor to the middle hepatic vein. This is our port placement, which is quite standard. We have a bit of different port placement for right and left hepatectomy. In general, though, the right hepatectomy port is a bit higher and is shifted to the right in order to be able to reach the hepatic vein, while the left is actually placed in the center of the abdomen. As you can see here, after the mobilization, now we're taking the inflow. On the right video, you can see here the isolation is basically done with a hook cautery. Once we get the tissue demarcation line, we mark it. We like to do ICG. We actually incorporated ICG in our practice. It is given by anesthesiologists, only 1 cc of diluted ICG prior to the liver transection. It gives us about 35 minutes or 45 minutes to get to the bile duct later on when we get to the bile duct part. On the left video, you can see here the lymphadenectomy is done because this is the intrahepatic cholangiocarcinoma. Like what Dr. Tim Pollock mentioned before, we try to get at least 6 lymph nodes during the biliary tract cancer. On the right video, you can see here, this is the action of the harmonic scalpel to transect the liver. It is important to do this as meticulous as possible, just like in open liver surgery. We try to avoid just blind firing of the stapler because it is quite barbaric and not precise. And when the tumor is close to the halar plate, it's a problem. You can see here the action of the dual Maryland technique. The Maryland, each of them can actually deliver energy for crush clamping to remove the parenchyma so you can expose the vessel. And if you have a little bleeding, you can touch the bleeding with the bipolar, and it works very well for hemostasis. On the left video, this is just at the inflow control. Now you can see here on the right video, as we move toward the halar plate, we utilize the crush clamp technique. Basically, very minimal energy. We isolate the bile duct. So this is not a blind procedure. You can see the bile duct, you can clear around the bile duct, you can ligate it, and you can scissor it. Again, crush clamp technique. You can see here the exposure of the branch of segment 4A from the middle hepatic vein. And it is actually quite easily done, and I don't think this requires so much of learning curve. On the right video, you can see here we walk along the Aransas ligament. We are back to the double Maryland technique again. This liver actually not on Pringle. This is just inflow control to the left. And you can see here we can expose the root of left hepatic vein in a bloodless fashion with 2 Maryland. And we actually just ligate it, put a clip on it, and cut it with a scissors. So this is robotic left hepatectomy, anatomical left hepatectomy with no stapler at all. Both the hepatic vein and the bile duct were handled with ligation and just cut. And you can see here on the left video now, we are getting at the parenchymal transection plate. Now this is a bit different. We have performed about 530 robotic liver resection, and we have tried almost all kind of technique to try to settle down of which one is the best technique for the best hepatic parenchyma. As we know, there is a bit differences in terms of consistency of the parenchyma from each liver. And we also learned over the years that cirrhotic liver actually require a bit different instrumentation than the normal liver. The cirrhotic liver is a bit difficult to use energy because it fractures easily as we close the energy device. and it actually caused a lot of bleeding. So on the left-hand side, this is mainly with the vessel sealer and a robotic fenestrative bipolar. It is a bit wider, but we can still see all the crossing branches. We can still expose them, and we can place a medium-sized clip or large clip, and then cut them with scissors. We try to learn from our Japanese colleague of a very precise parenchymal transection without causing any injury to the major trunk. This is also not done with Pringle, actually, because this is a left hepatectomy. In our program, majority of the resection that needs Pringle, actually, the non-anatomical resection. You can see here, this is the middle hepatic vein. Once we staple the left pedicle, the liver is basically open book. Now we're walking a cephalad toward the root of the left hepatic vein. You can see the middle and left being skeletonized, and we can see the junction of the middle and left hepatic vein. We can skeletonize them, leave the middle bare, and now we're transecting the Arantius ligament at the back. Usually I do it first, but sometimes we do it at the last part of this. And again, this is a handle without stapler. So on the left-hand side video, the staple is only used for bile duct because the tumor is segment 4A, therefore the tumor is far away from the bile duct. So therefore we don't think there's any concern with the margins. Now the specimen is detached. So this is a kind of a two different technique a bit in terms of resection. Now this is another view of using a synchroseal. So synchroseal is ultrasonic energy as well, but it has a curved tip with a bit smaller profile, because the criticism of the vessel sealer was it is way too big, it's way too bulky. So this is a right hepatectomy. We utilize again 2 Marilands to dissect the cava from the back of the paracaval caudate, a bit the crush clamp again, and to split the liver. Now we are stapling the right hepatic vein as well as the large inferior hepatic vein as well, being handled with staple. Now the synchroseal is also articulating at 60 degree. It can accommodate curved transection plane. It can hold the burst pressure 3 times its systolic. It has minimal thermal spread, and it acted like harmonic, except we don't see the articulating blade separately from the other blade. So they are kind of, put together between those two jaws. The other technique that has been discussed and published by several centers, this is a Luca Adighetti Center, but also there are a couple of centers in the United States that combine laparoscopic CUSA with the robotic instrument. And the reason why is because some centers really believe in CUSA. It does provide a good exposure and the skeletonization of the vessels, bile duct. So then they combine the approach. The issue with this method is you have to have an experienced surgeon at the bedside, and that usually means a second attending who has the basic of liver surgery to do this. And in our center and many centers, that is not available, and you cannot use a resident or medical student or an early fellow to do this, because next time is they're going to put this CUSA into the middle of the vein and suck the blood out. It happened to us before. So there is a good thing about this, but it's a bit of logistical issues with the staff. This is the last 2 videos that I want to show you. This is a right hepatectomy as well as a right posterior sectionectomy for HCC and hepatobiliary. Again, you can see on the right side here, we are removing the gallbladder, and the right posterior sectoral inflow is being skeletonized right now. You can see here the hepatic artery is being skeletonized, the right posterior portion being skeletonized and divided, which will give us the demarcation line. And you can see on the right-hand video, even the bile duct was able to be skeletonized quite easily with robotic system. I think the benefit of the robotic is that the dissection is very easy, and if we have bleeding, to repair it also, it's quite easy, and we shouldn't have too much stress doing this. So on the left-hand side of the video, this is a formal hepatectomy for hepatocarcinoma. We are mobilizing the right lobe. Again, we adopted the anterior approach. We mobilize the right coronary tragus ligament as much as possible. we divided the short hepatic veins of the cava. You can see here mainly with bipolar and hook cholangiocarcinoma. On the right-hand video also, you can see here the same stage of the operation. We place one clip on the cava side, sometimes two, but mostly one, and we utilize energy on the specimen side to do this. Now this is a demonstration of how we do a Pringle maneuver. It is like an old-fashioned open operation with a Rommel-like tourniquet. We use a 24 French chest tube, hold together with the vascular bulldog clamp. They can easily cinch down, and this gives us the demarcation line. You can see here on the right-hand video a very clear demarcation between the segment 6-7 and 5-8, and we will follow this for the transection line. Again, our probably the most common approach is with the vessel sealer in our program. The intraoperative ultrasound obviously is done routinely with any liver operation, including robotic or laparoscopic. And all the crossing vessels, we identify them intrahepatically and place a clip. Sometimes in the one hepatic section, we can use 30 clips. There's so many clips, but you know, believe it or not, this clip really cause problems. And when they stay on, they perform really well. Sometimes we have to add a stitch, but most of the time you don't need to. You can see on the right-hand video, this is the bile duct now being exposed. Liver is parenchyma split. You have plenty of space to cut the bile duct. You can see the bile a bit within the bile duct there. And you know, everything is done under direct visualization. So there's no more blind stapler, this and that. So that has passed, I think, years ago. We move cephalad toward the root of the right hepatic vein. We open the area behind the liver as we go. I think this is a safe procedures, because if we push to take down all the short hepatic vein at the beginning, sometimes you don't have room. And if you have a bleeding from the cava, it is difficult to control because the room is very limited. But if you open the liver and you go up, if you have bleeding there, the liver is open, you have access directly to the cava, and it is very safe. The right video is almost done. We staple the right hepatic vein with the stapler on the left side also. Essentially now the operation is over, and we just remove the parenchyma. Sometimes we use the extra staple for a big Makuchi ligament, and we remove the specimen. That is the different technique of liver resection that we use with different instruments. Thank you very much.
Thank you very much, Svanto, for the presentation and for the videos. Please, Riccardo, can you make a comment?
Yes. First of all, thank you very much, Matteo, for the invitation, and to Professor Torzilli too for this wonderful session. Svanto, I have a question. First of all, I am a big fan of your video, and as you have wonderfully demonstrated, it is possible up to now to apply different kind of technique in parenchymal transection in order to arrive to the same goal. But I'm curious about your experience. If you could choose the best one for you, which is among all this kind of technique?
Thank you, Ricardo, for the nice comment. And I know you are also educating a lot of European surgeons in robotic liver surgery, which is a very good thing. To your question, if I can choose which one of the best parenchymal transection, that I would do 2 Maryland bipolar with a vessel sealer. The reason why is because in robotic surgery, I think we have to be very aware of the cost of the instrumentation. So reducing the use of stapler, I think we have to work very hard for that. One stapler fire in robotic is $300. Okay, so this is why in the left hepatectomy, we try not to use stapler for the left hepatic vein. However, on the right hepatectomy, I think the staple is still needed because the trunk of the right is much bigger, and we don't want any slippage of the thigh or anything there. So 2 Maryland bipolar technique is basically very cheap because the Maryland come with the robotic basic set. And then the only instrument that we open extra is a vessel sealer that we can use for transection of the less than 7 millimeter crossing branches. and then you can open one instrument for the whole case, basically. So we ended up with that instrument. We try a different other instrument, but it seems like the one instrument that always works is the vessel sealer because of the articulation.
Thank you very much. I totally agree what you have saying in this comment, because double bipolar cheliclegia is the same technique that I use. And I think that vessel sealer is a very powerful tool, either for exposition and for transection of the vessel. I don't think the real use of the vessel sealer is for the parenchymal transection, apart from the superior layer of the subcapsular part, because in deep part, you have better result, I think, with double bipolar. And I think also that Professor Torzilli will agree with this Crash-Kelly technique, because he used in open technique. And so concerning the matter of cost and the possibility to have this kind of resection also with other platforms, because we are assisting to the arrival of new platform, I would like to ask you if you have any experience with other platforms apart from Da Vinci.
You know, at this point in the United States, the only approved robotic system is Da Vinci. So I know in Europe, I think Hugo is coming. And when I went to Australia for the robotic surgery meeting, there are about 30 of them coming, including the Japanese one, the German one, the Korean one, the Chinese one. So I think in the future, this technology will explode. They have a lot of similar feature with Da Vinci. But I think this is something that will be adopted in the more widely fashion across the world in about 5-10 years from now. And the costs are coming down. For example, the robotic system that is made in Asia, the cost is actually a quarter of the Da Vinci cost, with almost similar feature. So it would be interesting to see what happened in the market in about 5-10 years from now.
Thank you very much.
You know, one thing that I wanna add to your comment. You know, you are completely correct about the use of vessel sealer, because to transect the parenchyma with vessel sealer is kind of a bit of blind fashion. The better way of doing it is to do a crash clamp, and by doing that, you only leave those crossing branches, and then only when you see it, and you apply the vessel sealer to transect them, instead of a blind maneuver to take the whole liver with whatever inside and then try to make it seal. I don't think that is the best way. And you know, every time we talk about this, the Japanese protest. You know, I've had the Japanese came to the podium one time at the American College of Surgeons maybe 3 years ago. They hate it. They protest very hardly. Like, this is a bad way to do this. So you know, obviously we try to improve and learn our fellow to be as meticulous as possible, crush clamp, see everything.
Yes, I just had a comment, and then we close. And I think especially when you are in a learning curve performing robotic surgery, the thing that I say to my colleagues is that clutch clamping technique allows you to have small damage on vessel compared to other devices. And it is easier maybe to repair. And so I think it's a very good suggestion to who is approaching to hepatic resection by robotic surgery to start with double cheliclegia, because also of the possibility to control damage while you are performing. Because I have seen many videos of surgeons who perform this kind of approach, and you can appreciate when the vessel is arriving in the transection area or when you see the hepatic vein, and so you can go slower and perform a dissection compared to the use of any kind of sealer in which you could provoke some big vascular lesion or some damage that could be difficult to manage, especially at the beginning of the experience.
I completely agree with the comment. And in fact, I actually went to Saudi Arabia for a month to learn how to do a minimal invasive living donor. And this is how they do it with the cheliclegia and minimal energy.
Thank you very much.
Thank you very much.
I think, Eduardo, you raised your hand.
Oh, yeah, but I also wanted to highlight that there is a question here. What instrument typically have the forearm? Do you use robotic suction or any assistance?
That's a very good question. In our operation, actually, we have a fellow at the bedside that handling the suction. So the suction is to remove the blood, remove the smoke, and also give an intermittent saline injection to the area to kind of make it a bit wet, because that will make the bipolar more effective and more efficient, and we don't have so much blood. The robotic arm 4, I utilize atraumatic bowel grasper actually to hold the liver and to open book the liver. I find out that is probably the most easily found instrument, and they work very well because the jaw is big and blunt. So you can lift the liver easily with that.
And I did have a question for myself. In the bipolar, when you use the two Maryland, what's the source of the energy? Because the bipolar that give the Da Vinci is only going to give you coagulation. But I've seen some surgeon in Japan, actually in Nagoya, that connect the bipolar Maryland to the herb that can give you cut and soft coagulation. Is that exactly the same setting you use when we are talking about two bipolar?
It's exactly the same setting, and each of them has a different cable. So each of them can be activated separately, and we use a setting of 7 to do this. And we try all the different settings, but then we arrived that this is probably the best setting. You don't want to have too high of a setting because it's charring. It's like when you cook a meat, the outside is black, but then the inside is raw, you know? So you don't want to do that. You don't want to have too high of energy because you want the energy to have enough time to perfuse a bit deeper. So,
but you use the source of energy from Da Vinci, or you change to another source of energy? You know, you connect the bipolar to the Da Vinci, or you connect it to another one. Example, ERV.
You only have one energy device from Da Vinci.
Okay.
Okay, I have a quick question for you, Svanto, if I can. Air seal, yes or no, in particular for those cases with the exposure of the hepatic veins?
What's that? What's the question, Matteo?
Do you use air seal usually or not? In particular for those cases with the exposure of the hepatic veins for the risk of embolism.
Yeah, so I mean, this is obviously a hot topic that is discussed many times. I think it's also published 1 or twice. You know, in our program, we utilize a 5 millimeter air seal only. And the reason why we use that because you need a good constant smoke evacuation. And I feel air seal probably give you the best smoke evacuation. You can rely on the assistant, but it's better to have the machine take care of it. So then you always have a clean operative field. Now we do not use the big one because of the concern of air embolism. Most of the paper written about air embolism are from the big air seal, the 12 millimeter one, because those are really powerful and it can easily push CO2 into the hepatic veins. But for a 5 millimeter, I think it's quite safe. We've done many of those. We don't have issues with air embolism.
Okay, I think we can move on.
Thank you. Thank you. Thank you for Svanto for this very nice talk and also the nice discussion animated by Ricardo. And now we move to the conclusion. Svanto, if you can stop sharing the video because otherwise we still see your presentation. And there is a little change in the program because the title, it was a mistake to indicate the previous one, the real title, which is to be more interesting because it's really a pioneeristic experience. Biology of colorectal liver mets, role of somatic mutation and circulating DNA. And Professor Voté will give us his talk on this quite interesting and futuristic use of biologic marker.
Good morning, everyone. Svanto, if you could unshare your screen, please. Thank you very much. Thank you to the Italian chapter, and congratulations on all your accomplishment. Really, you've been leading in the SSAT among the chapters, and it's fantastic to see all all the accomplishments here. Can you see my screen?
Yes.
Yes.
Okay, great.
Yes.
So I'll review the biology of colorectal liver metastasis and sort of zoom out and give you a perspective and an update on this, and hopefully a wholesome view of how you should look at this disease, especially regarding the biology. We all have this goal of resecting and going towards a hepatectomy. We're hungry for hepatectomy, and when we see these patients, we really need to take a step back and evaluate the patients in a step back fashion, in fact. And here comes the imaging response, the anticipated margin, the mutations. You see resectable and unresectable liver metastasis are both treated with 2 to 3 months of chemotherapy pre-op at our institution. And this allows us to really evaluate the patient with a triple imaging before chemo, right after chemo, and before surgery. And this enhances the quality of the surgery. I'll first talk about the RAS mutation and to regards as to how it articulates with what we see in the imaging and in the pathology of the specimen. We give this chemotherapy. You see, the good news is that only a third of patients receive more than 6 cycles. So this is good news. We can minimize the injury from the chemotherapy. If you look at the genetic profiling, and you could get the genetic profiling immediately when you see the patient, either from ctDNA, I will talk about later, or even a biopsy from the primary without biopsying the metastasis, you can then move on and look at the response of the patient, and then after the surgery, look at the pathologic response, and then still use the mutation later when you decide on the follow-up of the patient. So if you look at these two patients, this is a great case on top. It's going to be a very easy laparoscopic resection, and you see the patient had a response, and yet he had really not a response in terms of pathology, a lot of tumor cells. You see the patient underneath with encasement of the hepatic vein, and the tumor became dark, cystic, and the patient, in fact, is still alive now after surgery. So you have this cystic morphologic response. It translates in a hyaline picture in the pathology slide with you know, a desert, no cancer cells in it. And you see that the RAS mutation underlies this response. You see, when you have a suboptimal morphologic response, your odds are fourfold higher to have a RAS mutant. Same thing, threefold higher RAS mutant if you have a minor pathologic response. So using really simply RAS mutation and then the size and the number of tumor, you can really obtain a metro ticket, similar to what Mazzaferro has done with the HCC. And you see this lower panel there, largest metastasis 2 centimeters up to 5. The survival is projected to be you know, more than 65% in this group, in this wide group. You say the same group of patients here, largest liver metastasis 2 centimeters, 5 metastases, you see you much lower. So really RAS can give you already, without even digging into the mutational details, really an insight into the prognosis as you see the patient before surgery. Now this RAS mutation can also help you in the follow-up of your patients. You see, there's only really one group that gives you recommendation on how to follow patients after liver resection. And you see here the axial imaging there's a recommendation from 0 to 2 years to see the patient between 3 and 6 months with a CT, and 2 to 5 years, 6 to 12 months. But if you look at these 3 to 6 months, you just follow the patient 4 times a year or twice a year. That's really an open question. And in fact, we looked at the effect of RAS mutation on the prognosis, and the effect of RAS mutation on the prognosis extends beyond 2 years. Up to 2 years, the usual clinical factors such as number of tumor and lymph node metastases in the primary influence the prognosis. But after that, if you have RAS mutation, you are at much higher risk to recur between 2 to 4 years. So based on this, based on the fact that the recurrence rate can be very high if you have RAS mutation at 4 years, 59% here, we proposed a follow-up that's guided between 2 to 4 years based on RAS mutation, with every visit every 3 to 4 months if you have a RAS mutation, RAS wild type visit 2 or maybe 3 times a year. So can you go beyond the RAS? Of course, you can go beyond RAS and dig deeper, and these are the mutations that can be found, and they are essentially RAS mutation, TP53 mutation, APC, SMAT4, FBXW7, NRAS, and BRAF. But if you summarize, you see that these mutations, in fact, are in 5 pathways and very easy to remember. And this is the size of the sphere represent the frequency of this mutation. You see TP53 is really the elephant in the room here. All these mutation, driver mutation, impact the prognosis, and they impact the prognosis adversely, except for APC. APC tends to improve the prognosis. And you have all these other mutations here. This other mutation here, these clusters here, except for BRAF, all these mutations are not really important. NRAS should be considered as RAS, so we call RAS, any RAS mutation affects the prognosis adversely. And when you look at the cumulative effect of mutation, you can see that, in fact, you can grade the survival of patients based on the number of mutations. So if you have 0 mutation, you have the best survival here after resection. If you have 1 mutation, but an APC mutation is the equivalent of 0 mutation, and grade 2, 1 mutation, grade 3, 2 to 3 mutation. On the right-hand side, you see the effect of this biology. This is the same effect of the biology on the survival outcome based on 3 grades. These are data from unresectable patients from the public domain database from Memorial Sloan Kettering Cancer Center. So we really would recommend that patients who are considered today more and more for liver transplantation for colorectal liver metastasis should be screened for mutation and may be considered for transplantation based on the mutational profile. Is mutational profile important? After resection, we performing more and more parenchymal sparing liver resection here, 76% parenchymal sparing at our institution now, 23% major hepatectomy. You see the number of extended and major hepatectomy going down over time. This translated into an increase in the positive margins. So what is the impact of this increase? Will this translate in increased local recurrence? Because this is the real question. Well, at our institution, we perform R0 intent surgical resection We used the CUSA and the saline-linked cautery. We used the two instruments technique to do the parenchymal dissection. And in fact, we found that in spite of having high positive surgical margin, 25%, less than 1 millimeter, the local recurrence has not been significantly increased. If you look at the factors affecting the local recurrence, because that's really what you should look at when you look at margin, you should look at local recurrence, not overall survival, because of the confounding factors in the overall survival. And you see that, in fact, the surgical margin status and the mutation do not affect the local recurrence, but only size of the tumor when it's more than 5 centimeters. So surgical margin, RAS, TP53, SMAT4, FBXW7 mutations do not predict local recurrence. Conversely, RAS TP53 co-mutation in the analysis was associated with intrahepatic recurrence. Now, I will just briefly mention the ctDNA. ctDNA is a new tool for medical oncologists and also, I would say, surgeons. Surgeons should use it. It's an expensive CEA, but a cheap PET scan in some way, and it detects minimal residual disease. It allows you an earlier diagnosis of recurrence, and for about 30%, 40% of the patient without evidence on imaging on follow-up, it can help you monitor the tumor burden, the response to the therapy, and it can also detect, assess the development of resistance. I think you should use it. We use it. It's reimbursed at our institution, and we use it now in the follow-up of our patient. This is a prospective study that we did on 48 patients where we evaluated the dynamics of the ctDNA, and you see here we had 9 patients. Please, these were evaluation that were done, 9 patients here who presented with negative ctDNA, remained negative after surgery, so about 20% of the patients. 40% of the patients had a ctDNA that was positive, that became negative after surgery, and the plus, they remain positive after surgery. So this patient obviously received chemotherapy before their first DNA testing, but this gives you an idea of the proportion of these groups, and you see that the ctDNA really predicts recurrence-free survival and overall survival. So how are we going to use it? That's the question. Are we going to just use it as a CEA or as a PET scan? That I think we should go beyond that, and we have a protocol at our institution looking at a hot topic. Had we de-escalate the chemotherapy, the treatment is really right now to give a doublet pre-op and post-op, but can you de-escalate? And in this protocol, we're going to look at after 12 months of surgery, we're going to allocate the patient negative ctDNA to de-escalate Z-load F5FU. Those who have a positive ctDNA will get the doublet they've received or a new doublet after surgery, and we evaluate whether the recurrence-free survival is the same at 1 year. So I think it's going to be an interesting way of de-escalating. These patients demand, they want to stop the chemo or have less chemo, and I think it's very important for our patient we can demonstrate no difference between the recurrence-free survival. So beyond the plus minus, whether it's positive or negative, the ctDNA can detect, in fact, the individual mutations. And you see here the mutational panel. You see also the variant allele frequency underneath the circle, the yellow circle here. this is a semi-quantitative measurement of the mutations in the blood, and maybe we'll be able to know more about these mutations and their significance based on this variant allele frequency. So do we use mutations in our practice? Yes, we do. We do, but it's not like, it's not to say, no, we're not going to resect based on the specific type of mutation, or yes, we're going to resect. No, it's not going to be. It's how we evaluate surgery, evaluate patients comprehensively before surgery, and certainly we can use it for the prognostic accuracy, as I showed you, for the surveillance in postoperative follow-up, for decision at recurrence, and a third of the patients I resect are recurrent colorectal cancer patients. So it's going to be in these patients a difficult decision sometime. I'm going to re-resect, ablate, or even send the patient to transplantation, or just say no, give chemotherapy. And finally, post-op therapy, maybe we'll be able to de-escalate, give only 5-FU, maybe no chemotherapy before surgery based on the findings. I thank you very much. I thank the Italian chapter for their kind invitation to speak today, and it was a very enlightening discussion, and I hope it's going to continue with Dr. Spolverato. Thank you very much.
Thank you very much, Nick. And now you anticipated that the discussant is Professor Spolverato from University of Padua. And then Gaia, you like to raise your comment, question?
Yes, thank you, everybody. Thank you, Professor Botte, for the great talk. And we all read your recent paper on biology of colorectal liver mets, but I'm glad to be here to discuss it with you. So our increasing knowledge on genetic alteration allow us to use them as a prognostic factor alongside with traditional risk factor. But in clinical practice, how do we select patients with colorectal liver mets for resection or transplantation? And how do we guide surveillance based on tumor biology, even beyond the RAS? Will we have an algorithm in the next few years?
So I try to show you, it's not a black and white, okay? I think you should have these mutations at the beginning, and if you look at the NCCN, the recommendation is to obtain the mutational profile at the beginning when you see these patients. So it's like it's part of your passport, it's part of the fingerprint of the tumor, and you should have it. And as you look at as you start treating these patients, it gives you a much better understanding of what's going on, and it's not going to be just seeing the patient for surgery and doing surgery and this is over. I think you're going to look at the CT scan better, as I showed you. It's not RECIST response; it's this morphologic response, dark. The metastasis gets dark. Then you look at the response and the pathology when you meet with the patient after surgery. So as I see it, with this, there are some cases where really you're on the edge. You say, okay, this is maybe a patient, I'm going to do more surgery, more extensive surgery. Is this worth doing? Is this worth taking the risk? Is this worth myself spending 8 hours in surgery for this tumor and for this patient? It's an affair of the heart. And then how do you disconnect yourself? You want to have something objective that helps you. So I think this is where it's most important. And then if you look at the question is about liver transplantation for CLM. If you look at the literature right now, there are almost more papers than patients being transplanted for this. So this is, there was just another consensus meeting or meeting on this in Boston last week. So and there were like 40 experts, and we've done very few patients. In fact, we've done 3 here in Houston, and out of the 3, 2 recurred. We have a protocol, 2 recurred, and 1 is NED, but in the pathology specimen, the patient had no cancer. So, and that's something you don't even read in some of these papers on transplantation for colorectal liver mets. Was there tumor in the specimen or not? So I think there's a huge denominator, and a small numerator. And I think we have a protocol at our institution. We follow the protocol, but we should be very selective because we have so many options now for these patients.
Thank you. Thank you very much. I have another couple of questions, but I'll go with the first one. The time of precision oncology is still the time of hepatic artery infusion chemotherapy?
So that's a loaded question you're asking. There's a revival. I trained at Memorial, so but I don't have a conflict of interest at this point. So I put pumps for about 5 or 6 years, and I have great admiration and respect for Nancy Kemeny, who developed this approach. I still think it's a modality that's in the search of an indication. When are you going to put the pump? Are you going to put the pump after liver resection, or you put the pump like patient is unresectable, and the new quote unquote indication is to extend all this until we can transplant? I would say no. When you decide to transplant, you should decide to transplant within a year, very soon, very quickly. I mean, this is patients, and then there are rare patients who survive and still have mets unresectable, and you transplant. But I think to say, I'm going to put a pump and then we'll transplant you, I think you should be very, very clear on the indication. So we're still waiting for an indication and a level 1. I don't think we have level 1 evidence to support its use based on your protocol. For sure, you can enroll patients on protocol for hepatic artery infusion.
Do we have time for a last question?
Yeah,
Guido.
Yes,
yeah.
Yes.
So I recently read your paper with Paolucci showing that genomic alteration in cancer-related signaling pathway can predict different progression patterns and the likelihood of receiving salvage local regional therapy after percutaneous thermal ablation of CLM. Can you comment on the importance to define factors contributing to disease progression outside the ablation zone? Is this something that we're going to discuss more in the near future?
Yeah, I think it was a very complex paper using AI, and I think we were able to put it in a high impact factor. It's like these papers with complex subsets with different progressions. I think we have to be very, very careful, but there's an overarching theme you've seen here in my presentation is that if you have double mutation, RAS TP53, or another combination of co-mutation, I think the news is really, and no APC, I think the news is not so good for the patient, and that's what you should keep in mind. And I think beyond that, I think these are subsets analysis and difficult to apply in your practice.
Okay, thank you.
Thank you, Gaia. There is a question from the audience. Is Dr. Garcia Herrera, who is asking you, Nick, what is your experience and actually policy regarding colorectal resection, colorectal liver metastasis resection in patients treated with immunotherapy? Should they be resected or maintained only on immunotherapy if disease is being controlled?
Yeah, that's a big question, and I think right now the medical oncologists tend to keep the patients as long as they do okay, and they use, you know, they do what they were doing with chemo, with immuno, you know, 20 years ago, they would send us only the patient who were progressing on chemo. So I think we don't have the answer right now. These patients it's a very rare group or subset of patients, because these patients on immunotherapy typically don't have liver mets. So there are very few patients with microsatellite instability who have liver mets. So that's a very very small subset. But you know, as long as the patient is followed well and the immunotherapy is well tolerated, I would not, you know, have any objection on this.
Thank you, Nick. Thank you. Thank you very much. And I let Matteo close it.
Yes, if there is no other question, I think we can conclude this webinar. Thank you very much to all of you guys to be with us and with the Italian chapter of the SSAT. I think we cover most of the important topics that nowadays we work on in liver surgery. And goodbye, everybody, and thank you again.